Hey everybody, I'm Raj Kumar, President and Editor-in-Chief of Devex, back again with one of my leader conversations during this pandemic. Really excited to have Jono Quick, somebody I've known for many, many years, and he's literally the guy who wrote the book on this. He's the author of The End of Epidemics, came out a couple of years ago now. He has many hats over the years, but currently is leading up a new role at the Rockefeller Foundation in charge of pandemic response. He was the president and CEO of MSH, Management Sciences for Health, one of the leading global health nonprofits in the world. He's an expert on health systems, obviously on epidemics, part of the faculty at Harvard, at Duke, at BU. You've just had an incredible career in global health, Jono, and I'm eager to hear your take on all that is going on. I know you're in high demand these days. Look, we're today over 5 million reported cases around the world. Over 300,000 tragic deaths from the coronavirus. How do you see the whole situation today, and how do you see it unfolding?
Well, thank you, Raj. Thanks for the question. Thanks for bringing me in. For folks who are wondering about their futures, Raj is one of at least 3 folks who in graduate school got an idea to launch a business. He was at the Kennedy School, and he's joined the lines of people like the founder of FedEx and Mike Dell, the founder of Dell, who were inspired by graduate school conversations or projects. So pay attention, there's a future ahead. So on the current coronavirus, I mean, it is just a stunning example of what epidemiologists long before I wrote the book, The End of Epidemics, have been warning. We're living in a riskier world. I mean, we have built a world that is more intertwined and has more areas of vulnerability. We've enjoyed the fruits of all of the benefits of that, but we've not really taken care of the fact that we're traveling more, we're more crowded. We have areas of conflict. We still have big pockets of poverty and vulnerability. So I think that it's really been stunning to see it go global.
Yeah, I mean, you can go back and read your book, published in 2018, and you talk exactly about this. And I know there's still people to this day who said, "Oh, we could have never seen this coming. This is unimaginable." That is not the case, right?
No, I mean, nobody who knows pandemics, nobody knows even the coronavirus. The coronavirus was number 2 on our most wanted list. The first was a highly deadly, highly contagious pandemic flu virus like we had in 1918. The coronavirus has proven to be less deadly, but to be a really kind of a stealth virus, the way it's gotten around. So it's in the sense of spread and all, it's been the classic pandemic virus. Respiratory spread, in this case, not just like the first coronavirus in global SARS, which was mostly down in your chest. This is like, it's a kind of a functional hybrid between the common cold coronaviruses that spread easily and don't cause much disease, and a classic sort of SARS virus that's really deadly.
Yeah, so it's almost the worst of both worlds, right? Because it does seem to be highly contagious, just like a common cold. You can pick it up so easily.
Yeah. So that's created a huge challenge. And I have to say that one of the things that it actually, when I go back and read some of the parts that we've written, we talked a lot about civil unrest, kind of riots in the street, from the grocery stores, the kind of, if you've ever seen the movie Contagion, there's clips of people, The thing that's been, I think, reassuring about humanity is that we've had outbreaks of threats and some violence, but we have tamped down, we have globally plateaued this virus. So a new virus, it's only been with us for 5 months. We've actually plateaued that, and countries have brought it down. And that has involved a huge, a historic degree of social cooperation and social responsiveness in countries. So
it is amazing to see, including a lot of low-income countries, you know, where high percentages of the population work in informal jobs. So it's not easy to have social distancing, and a lot of them have achieved it. But kind of implicit in what you just said, John, I just want to understand, yes, we've gotten maybe somewhat to a plateau, but certain parts of the world, you're still seeing increasing case counts.
Absolutely.
And a lot of people are talking about multiple waves. Are you seeing that where we are today is kind of, we've got this thing more or less under control, or do you think there's still many more steps ahead of us and this could grow?
So 2 points on that. One is that it is always the poor and vulnerable that suffer the most. When we looked at the 1918 flu, we had a 4-fold difference among our cities in the death rate, flu death rate. Half of that was attributable to poverty, pollution, coal burning back then, and poor health before. So this is one of the real travesties because it has revealed the inequities and the impact, economic impact, the impact on food supply is critical. So where we are now, very, very vigorous social distancing has brought this down. That's what's done it. And the evidence back in 1918 and the evidence today is those places that started early and kept with it longer have done better. But the virus hasn't changed. 95% of us, plus or minus, are still vulnerable. We haven't got it. We're still vulnerable. And it's gotten pretty much everywhere. So when you have a pandemic virus, it stops when one of 2 things happens. It runs out, you get a vaccine and you can control it that way, or it runs out of fuel. We're the fuel, unimmune people. So until 60 or 70% of us are immune from getting it naturally or from vaccine, we're all still vulnerable. So what that means is really 3 things. One, as we relax social distancing and all, we need to keep up our personal, as we open up our workplaces and our communities, we need to be vigilant about personal protection. Distance, masks, hand washing. They work. They'll save infection. They'll save our life, our workmates' life. That's number 1. Number 2 is testing. We need to know there will be outbreaks. I mean, there will be waves of outbreaks. Whether we get a big second wave, that's mostly in our hands. The virus is going to do what it does. It's up to us how we respond. So
because a lot of what I hear about that second wave is that it's potentially seasonal, right? I hear a lot of people talking about, well, you know, it's going to go down in the summertime, particularly in places like the East Coast of the United States, and then it will come back up in the fall. You think it's much more really about how we respond?
So, well, yes, absolutely. There are some seasonal effects. The respiratory viruses tend to be seasonal, but pandemic respiratory viruses don't tend to be as seasonal. The other thing is that when you get, it's the double wave that I think is the biggest concern. That is, we relax, it gets cooler, coronavirus comes up, and then flu comes up. And that really would be a double whammy.
And then to explain that, because I've heard that there the issue is people show up in hospital rooms, you know, in emergency rooms saying, I've got a respiratory problem, and we don't know, is it the flu or is it the coronavirus? Is that basically the major reason why that's so worrying, that you'd have that double wave? It's
the volume. It's the volume. And there's nothing that says you can't get both viruses. And right now, in emergency rooms in this country, I know because my son-in-law is an emergency room doc. He has a choice. He has somebody with a fever and with symptoms and all, and they're short enough of testing that he has to choose: am I going to do a flu test or a coronavirus test? Because they use the same reagents. So it's going to be a real challenge on the health system, which is why number 1, we need to get our flu vaccines. Flu vaccines are preventive for a third to 2/3 of the time. That's a good bet. So we got to get our flu vaccine. Older people, people in risk need to get their pneumonia vaccine because it's the bacteria pneumonia. And the other thing is we've got to ramp up coronavirus testing so we can get the peaks early. What you don't want is a peak that you first see when your emergency room's overwhelmed. You want to know it's coming because you've got community-based surveillance, because you've got workplace surveillance, and because you've got nursing home and prison surveillance. That's critical. That's why at Rockefeller, one of our major initiative has been what we call the 1-3-30 strategy, moving from 1 million tests per week now to 3 million tests per week by the end of June to 30 million by fall. We can do it. We have the finances to do it. We've got, I mean, if we put them in the right place, we have the technology and the innovation to get the tests. And the other part of this that's really critical is the contact tracing. And like a lot of things, humans learn technically first. So we've got these contact tracing apps and we're training contact tracers and all. But we need a major public communications because we're talking about a huge behavior change. I mean, imagine you get a phone call out of the blue. Maybe you're sitting in New York and it turns out the contact tracer group is in Chicago. Hi, you tested positive. Here's what you got to do. I mean, we're not used to that. Yep. So we have to, we've got technology, we've got behavior change, all of which the whole idea is keeping our workplaces and our communities open. That's the goal. And to do that, we've got to take the virus seriously. We've got to adjust our behavior. We've got to do testing, and we've got to know where the outbreaks are.
Let's dig into all that a little bit more. Okay, thinking about testing.
Yeah.
And, you know, understanding, as you know, somebody who works in global health, capabilities are going to be different in many different countries, low and middle income countries, highly dense populated urban areas, slum dwellings versus, you know, advanced economies that are more spread out. How do you see this really going? Is testing going to become something, when you talk about 30 million tests, is this going to be something where you get a kit in the mail, you know, that something is sent to you whenever you feel like you have symptoms? Or are you going to go like before you walk into your workplace every morning and someone's swabbing your nose? How do you expect this will actually roll out?
Well, okay. I've been in global health long enough to see people imagine the impossible and then make it happen. The guy who led the charge against smallpox eradication, the greatest public health achievement, it took him 15 years to convince the world's leaders, and some of whom said it's impossible. And it's because they thought you had to immunize everyone on the planet. No, you had a strategy. We did the impossible. If in the year, at the turn of the millennium, if you had asked people in the global health community, given where we were then, AIDS a chronic disease in the north and a death sentence in the south, can you imagine 17 million people on treatment when the cost was $12,000 per person per year? They would have said, no, not in the world I know. We've done it. So I think we can get to the point, my impossible, which I would challenge, is a little printer-sized box at home, and you take the swab and you put it in there, and it tells you stay home or go to work, stay home or go to school. And this is linked in an anonymous way, so we kind of know that's the kind of golden ring.
And so then you could see on a map, you could be able to see, okay, there's an outbreak here. We're getting a lot of positives in this area, in this cluster.
Yeah. And that gets into the whole area about privacy rights and all. And I think we need to recognize there's there's rights for and there's rights from. I have a right for free speech, for privacy, for safe roads. But I also have a right to be free from violence, sexual violence. Your freedom to do what you want it ends when it encroaches on me. And I have a right to be protected from my neighbor unintentionally killing me by spreading a virus. And so I think we're going to need some of these kind of attitudinal changes that let us weave this testing into a basically a protective network.
And we might need to have certain protocols that say, okay, if you opt in, or if everybody can be monitored in terms of whether or not they have the virus or not have the virus using a swab test like that, that doesn't extend to just kind of, eternal monitoring of everything. If their device is set up for an app to allow you to do contact tracing, it ends there. It's very restricted and narrow.
Yeah. Yeah. And I think if we have a certifying process for apps that really make sure that they are locked and all, there's going to be some linkage. But I mean, there's nothing more you're going to be learned from a contact tracing app than probably the really clever marketers don't already know. So,
yeah. So your expectation, I mean, thinking about a country like India that's still seeing caseload grow, they're anyway planning to stop the social distancing or relax it soon.
Yeah.
How do you see things unfolding in places like that where doing social distancing is so tough?
Yeah.
Cases are still growing, even regardless of the weather, the heat and the humidity, it seems to be growing. And you've got, health systems that aren't as strong as in other parts of the world. How do you see that going?
Well, I think, and we are, Rockefeller is not only engaged in the U.S. testing, but internationally. We've commissioned a supply chain assessment for testing and are looking at some projects in India, which has incredible production capability. And so I think that's one thing. I mean, they're part of the solution. I mean, it was India that got us to $1 per person per day. Really high-end, clever Indian AIDS drugs manufacturers. So that innovation there will help them scale up on testing. But I also think that we have a large ongoing public education effort, and we just need to keep at it. What we know is we can change health-related behavior, but it takes a combination of interventions working synergistically. It takes the TV, it takes opinion leaders, you get cricket stars and others who will say, which by now I'm sure that any field has athletes and stars who've gotten the coronavirus. So you need your influencers, you need a evidence-based, consistent set of messages coming out from the government and from NGOs. And you need the community level folks. I mean, that's the other thing. Contact tracing, as an example, works well when it's done by trusted people in the community. So you really have to step back and say, we need all these different pieces in place with a consistent set of messages. And yes, you're not going to be able to, in crowded communities, you're not going to be able to do the same thing that you would elsewhere. But I mean, I was really touched. One of the things I did for writing the book, The End of Epidemics, we visited villages in Liberia after Ebola that Liberians wouldn't visit. But they were clear of Ebola, and sitting with them to hear their stories of how they cared for each other was really moving. And so I think it's an adaptation. And I can tell you that already while we're thinking about it here, there are places in India and everywhere where people at the front line have figured out how to deal with this new, really bizarre situation. And I think that's key. Another thing we've done as Rockefeller is stand up a testing solutions group, which has a dozen cities, states, and tribal nations interchanging with each other. We heard a great story yesterday from Navajo Nation. And they were very practical learnings. Last week, 2 weeks ago, we heard from New Orleans, from Dr. Vigneault, the head of health there. They had a huge spike. And she understood the community, she mobilized, she innovated. They found that the drive-through testing sites, people that needed testing didn't have cars. So they had stand-up sort of pop-up testing sites, mobile testing sites. So those sort of frontline innovations by people who understand the dynamics, that's all part of keeping societies and workplaces open.
So I'm just trying to do what you told me to do, which is imagine the impossible being possible. And it sounds like the world you're sketching, Jono, is, we went through this incredible human experiment, never before seen, global social distancing, people locking down, that's starting to open up. And so the next phase is another kind of huge social experiment where people stop shaking hands. They start washing their hands much more. Maybe they're all wearing masks. I mean, huge percentages of the human population walking around with face coverings of some kind. And then that goes on potentially for 12 months like that. Yeah, 12 months, a year, because it's going to be a long while, I presume, and what we're hearing from other epidemiologists I'm talking to, before you get a vaccine that has gone through all the trials for safety, that we know the dosing, and then we can get it out beyond health, frontline healthcare workers. So are we looking at maybe the next year or so or more of just massive global social distancing with testing layered in and with contact tracing on top of that? Is that how we should expect the next year and a half to go?
So I'd actually say a little bit longer. But let's take the vaccine part. Normally, like with Ebola, which went quicker than most other vaccines, it was 5 years. But there's a fascinating analysis that says, okay, if we can shorten each of the dozen or so key steps from lab to manufacturing to distribution, start overlapping. Don't wait until until you have the vaccine to build a factory. I mean, Bill Gates is already committed to building 7 factories, even though he doesn't have the vaccine yet. So we can speed it. If we speed it, it'll be somewhere between, and we're fortunate, it'll be somewhere between the late spring and the late summer that we get it. But even with a massive effort, I would be surprised if it doesn't take at least another 6 months or more to get the level of vaccine we need. So
and is that to get it out to the whole world? There's a big concern about whether you're going to get vaccine everywhere, or wealthy countries will get it first and it'll take a long time to get to the low and middle income countries.
Well, so here's the thing, and I think the WHO statement that came out either earlier today or yesterday talked about the vaccine needs to be a global public good. If we do that, and the vaccines that work, that those developers also do transfer of technology, so that we can produce. And this isn't a competition. This is a cooperation. We need to keep every part of the world safe and productive. And so India has world-class vaccine producers. China is both the biggest producer and the biggest consumer of vaccines. So if we can do with the vaccine what we did with the genome, China got the genome, they published it. It's the first time in history you had diagnostic tests being made across the world in weeks from the downloaded genome. And so if we do the same thing with vaccine, more complicated, but the idea being we develop it, but not with the idea of those of us who developed it, produce it and have it, but that we share the technology so we get production going in all parts of the world, not all parts. That any country, there's maybe a half a dozen countries that have significant vaccine production. Get them producing ASAP. And vaccine production is critical. So you can't produce flu vaccine until Friday, turn off the flu vaccine and come in Monday and turn on coronavirus. It just doesn't work that way. So you're gonna have to have purpose-built factories. But do that now, the economics of it are overwhelming.
John, how should we think about the issue of mutation, of the virus mutating? I've heard this from multiple people that they expect there's a high likelihood viruses like this do mutate. Does that affect the vaccine development? What would it mean basically if it mutates?
The nightmare scenario for that is flu, because it's constantly trading genes between waterfowl, humans, swine. It's constantly mutating. Part of our problem with flu vaccine is that because of the way we make it, it actually changes once from the time we start to the end. as it turns out, the coronavirus has not proven to be to mutate. So far as I know, and I'm sure your audience will correct me, but we haven't seen mutations that have made it either more contagious or more deadly. Not to say that couldn't happen, because when you have so much virus going on, and it's really a genetic roulette, we have billions and billions of coronaviruses around now. They could mutate. Hopefully, the vaccine that we develop will get the part of the coronavirus that doesn't mutate. Our mission to get a universal flu vaccine, there are different strategies, but one is to make the vaccine to the part of the virus that changes the least. The reason why we're constantly chasing the virus is that the easiest parts of the flu virus to make a vaccine to are the ones that are the most changeable. So if we get the steady parts of the coronavirus, we should be, that's the ideal. We won't really know that until we put it into human trials. One of the things about vaccines, it's vital that we don't rush the process in a way that shortcuts safety. It would be disastrous if we end up not fully testing the safety, and all of a sudden, on top of all the other skepticism that we have about vaccine, that we have a problem with safety. I mean, no virus is 100% safe, but what you don't want is a situation like we had in the 70s, where we had an alert about a swine flu virus, an H1N1. We made a vaccine. The virus decided not to make a pandemic, and the vaccine had side effects. So that we can't repeat that.
Well, and in this case, the virus seems to affect older people the most, and you have to really get dosing right for older people, right? Because vaccines sometimes require a higher dosage.
Yeah.
So,
yeah. Yes, indeed. The other part of it, and this is what people say, why do the studies take so long? Part of it is the big picture safety, which you learn with a small number. Part of it's the efficacy, and then it's the dosing, and then it's the subgroups. You start with the healthiest people when you're doing the testing, and the middle-age groups, but then you want to know about a childhood, and we may decide there are certain at-risk kids. You want to know about pregnancy, you want to know about different ages, and so those are the things we need to learn along the journey to develop the vaccine.
You spent so much of your career thinking about strengthening health systems in places where they're weak. You talked about Ebola in Liberia. It's a good example. What's your thinking for places where health systems are really weak? What should we be doing today about that?
Well, first of all, we should be keeping on the investment in strong health systems and the universal health coverage vision. I mean, countries don't get there overnight. No country's gotten there overnight. But you'll never get there if you don't have that vision. So saying, look, we'll provide the basics. Part of living in a 21st century society is access to basic health care. So strengthen the basic health systems. But the other thing is to realize it's not outbreak surveillance or primary care. It's not one or the other, it's both. So you want to make sure frontline health workers, with all of the fancy testing things and everything else, it's vigilant frontline health workers who have picked up SARS, who have picked up Ebola, who picked up coronavirus. And so that awareness. The other thing is, we started as a world community 100 years ago, countries talking to each other about how to deal with infectious disease crossing borders. 50 years ago, WHO was started when we had the international health regulations. It's only 8 months ago when a group called NTI and Johns Hopkins and The Economist published a Global Health Security Index. So we have a scorecard for every country, 0 to 100 scale, on how prepared they are. Health systems is an important part of that. And so you want to be sure that there's awareness of the importance. And honestly, if I was a business, and I was thinking of going into a country, I would know the number. I want to know what that country's number is. And if the number is low, as a lot of countries are, I would not go to the Minister of Health. I'd go to the Minister of Finance and I'd say, we're thinking of, starting mining West Africa, or we're thinking of doing whatever, but we're really uncomfortable with the fact that this place, you're not safe against these catastrophic pandemics.
It seems like a related issue, and maybe it's more specific than the broader strengthening of the health system, is this point that you're making about kind of the phase 2, right? We're in the social isolation, social distancing right now. You want to open up, but you need the testing, you need the contact tracing, you need PPE, you need masks, right? So it seems like quite a debate happening in a lot of the world about when to reopen, quote unquote. Is that the right debate to be having? Or what do you think we should be focused on and paying attention to today?
Yeah, well, okay. I think, reopening is, because pandemics kill 3 ways. The virus kills. The disruption of health service kills. We know that in West Africa and in other outbreaks, there was many deaths from disrupted care, maternal and child care, immunization, and malaria prevention, as there was from the pandemic. The third is that economic disruption kills. The 2008 global recession, just on cancer care alone in high-income countries, was responsible for at least an extra 250,000 deaths, because that economic disruption ended up having a knock-on effect on access to healthcare and all. So it's not like the choice is open up or save lives. No, the question is, how do we open up? When and how do we open up? And then how do we keep open? And so I think it doesn't make, when you're still on the up curve, that's not the time to open up, because it means the virus is growing, but it also means people haven't understood the nature of the virus. So a plateau happens when you got enough people, you sort of have herd awareness. So, we're not immune, but herd awareness is actually, if you think about it, that's what is saving lives.
Did you just coin a new term for us right now, John?
Yeah, I did. But that's what it is. And so you have got to demonstrate it, that you can plateau it, because it doesn't make any, it's not like staying inside for a while. A lot of people staying inside changes the virus. It doesn't. And so number one, you've got to be sure that you're at a plateau. And number two, you need to be at least getting going on the keeping it open strategy. So I think a lot of folks have only, leaders and all, have only thought to when do we open up? But you've got to also think about, how do we stay open? The other thing about the opening up is, so one, you've got to at least demonstrate you've plateaued it. The second is that you then need to use that time to prepare your health system, and to be sure that you have surge capacity and you've really thought that through, because there will be outbreaks. We don't know where or how big. And if you're a small community with a small hospital, you're also at risk of being overrun. And so you need to have those plans for how you will continue healthcare. It's just, why in a war do some enemies shoot the medics first? And that's the story we heard from Vietnam. It's because it demoralizes the troops. And so we've got to be sure that we are protecting our health workers and all, and that has to keep happen. And I think if you're not ready to handle the surge, you're not ready to, I'm going to sound extreme on this, but if you're not ready to handle potential recurrence, you're probably not ready to open. And then we're going to have to do a catch up with the testing. We've just got to move ahead and open up, but open up with a clear sense of our keeping open strategy.
What do you think about schools in particular? How do you think about that? There's a big debate about opening schools around the world now. How do you see that fitting in?
Well, we can look at what are some of the different strategies that have been used in pandemics before, because I don't have a comprehensive answer to that. But some of the things, I mean, first of all, vigilance about, particularly with just monitoring for the virus in some sampling way with faculty and all students, and having a good reporting of where there are cases in the community. But the other thing is, the other techniques that have been used is to stagger classes through the day, so that you may end up saying we're going to have 3 different classes, so that, and keep the buses moving and all, so that we're not as crowded on the buses and we're not as crowded in the school. And those sorts of really thinking, okay, because at least that'll give some respite, because it is, I mean, what this is doing to families in terms of kids at home and all of that, it's incredibly stressful.
Well, so, including healthcare workers, right? You talked about the importance of putting them first. Think of all the healthcare workers that have kids, and that's limiting their ability to do their work as a healthcare worker, or, you know, putting at risk their families.
Yeah,
that's a huge component of this to think about.
Yeah.
And we have actually at Devex, we just launched, for those interested in healthcare workers, a whole campaign called Duty of Care, which is really diving in and talking to those frontline healthcare workers all over the world, including places that have weak health systems, about, you know, what does it look like from their perspective, and what do we need to do, you know, to think about protecting them and being capable of handling those surges. I guess, John, one other thought: what should we be concerned about? What should we be worried about at this point? If, you know, what are you worried about? I guess I should say, what are you most paying attention to?
Well, I think in the near term, what I'm most concerned about is inconsistent and conflicting messages about sort of who to trust and what the best approach is. And there are a set of principles around communicating in pandemics and health emergencies. And the CDC developed them after the SARS outbreak. That's when they really started, you know, 6 principles of crisis communication, which they teach to everyone from governors to community or to county health leaders. Basics like, you know, be first, get the message out, be truthful, say what you know, say what you don't know yet, be empathetic, tell people what to do. So I think this sort of consistent messaging. My biggest concern is whether, I mean, we're in this position, in my view, because of the cycle of panic and neglect. We panicked with SARS back in 2003. We panicked a bit with bird flu in the mid-2000s. We panicked with Ebola, which was never going to go global in 2014 in West Africa. It set Twitter records. And whenever that happens, we have the thousands of pages of reports and billions of dollars committed. But you come back a few years later, and there have been some improvements, which there have been great improvements in Ebola, but not enough. So what I would say is, remember this moment. Remember how you're feeling yourself. Remember how your kids are feeling, how your spouse or partner is feeling, what's happening to your parents, what's happening to your workmates, what's happening to your community, and realize that, number one, this could easily happen again, and number two, I don't think it needed to be this way. We were going to have an outbreak. A coronavirus like the one that came out was inevitable. But what I don't think was inevitable was that the idea that it wasn't, the message didn't get up at the local level because we hadn't had that awareness down to the local level, that when your health workers say there's something different going on here, you got to listen. And, you know, even if it had been a few weeks earlier and not hit the worst possible kind of place, busy city with Wuhan, with transport, just before a holiday season, the biggest traveling season, I think that's probably the biggest travel holiday in the world. It exploded it. So, I mean, timing matters. So the point is, we can make the world safer. Scientists and public health people know what to do. It's cheap compared to, I mean, it's a pittance compared to the cost of not making it safer. And the question is, will we as the citizens of the world really keep the pressure on our leaders to do what they know needs to be done? Because they're going to be facing a really difficult challenge because we've got fewer resources, a lot fewer. Pandemics have a longer tail than other sorts of crises. So we're going to be suffering the economic consequences. But we've got other crises brewing, like global warming. So it's going to be a tough environment to make the case, but we've got to make the case. Because we can't.
I know that's a lot of the reason why the Rockefeller Foundation has stood up this new role that you've now taken on. And it's something we are going to be following really closely here at Devex. You know, we're covering this COVID-19 pandemic from all aspects, major focus on global development, on the low-income countries of the world, the places with the weakest health systems. And it has been really fascinating to just get a chance to peer into how you're thinking about this, Jono. So really appreciate you taking the time to do it. And we will be following your work really closely. Thank you to all of you who've been listening to this conversation for following us on Devex. Stay tuned for more.
And no, thank you, Raj. Good to be with you.